All right, everybody. I'm going to start this with a quick introduction to how this class is set up. You've been provided with PowerPoints that are designed really to be an outline of the medications that we're covering in Pharm this semester. And then there's a voiceover component of the PowerPoint, and that's there just to help you fill in the notes. So the best way to fill these in is probably just to print them off. So print off the PowerPoints, listen to the voiceover, and fill in the notes as we go along. The voiceover component is going to allow you to go at your own pace. You can go back and replay parts as needed, and just take your time filling in those notes. Physically making the notes with a pen and a paper, it's been found to increase not only retention of the information, but also the ability to use the information. It's not to say you can't type them out. By all means, type them out if you want to. But I have definitely found with my students in the past, the best way for them to retain the information and then be able to utilize that information is to actually work with the information that just doing notes by hand does honestly help with that. But you do it however you want. Okay, and then as far as the book, you use the book to go back and clarify medications and principles that we cover in these notes and during class. So I definitely would read the parts of the book that we cover. And what I mean by that is there's going to be meds in the book that we don't cover in these notes. You don't need to go through and read all of that stuff. The meds that we do cover, I would just go back and browse through what the book says just to give you another perspective on it, and it will just help further highlight the information and clarify some things for you. Again, if the medication's not covered during these notes or during class, there's going to be a few meds every once in a while that we'll talk about during class that aren't necessarily in the notes, that you may want to use the book to go back and to get some more information on. But if it's not covered in class or during the notes or in the notes, I don't put those meds on our tests. So you're not responsible for knowing those medications for my test personally. Now, ATI or NCLEX, that's different. But the goal here is not to learn every med. This is not going to happen. You're not going to learn every med. It's a big book. We can't cover every single med in that book. So we're going to cover the major categories of medications and what you need to know for those. And then with each of those, I'm really only going to expect you to know a couple from each of those, and some of them only one. Some categories maybe a few more because they're just so much more common. But that's kind of how I have this whole class set up. All right, so let's go ahead and get started with our first discussion. This is Introduction to Medications or Introduction to Drugs. So pharmacology, what is it? Your book's going to define pharmacology as the study of the biological effects of chemicals. Nurses, as far as we're concerned, we're really dealing with pharmacotherapeutics. And that's like clinical pharmacology. It's a branch of pharmacology. We deal with how these medicines are used for treatment, prevention, and diagnosis of diseases. And that's really what we care about. There's other branches, certainly, but we're not creating the meds. We could be involved in testing of the medications at the bedside level and collecting medications at that, collecting information at that level, but we're still, even if we're involved in those programs, we are, as far as nurses are concerned, are really only dealing with the pharmacotherapeutics of it. How are these medicines how are these medicines treating, preventing, and diagnosing diseases? As far as nurses' responsibilities, I missed drugs. So the drugs component there is, all that is just chemicals introduced to the body to cause change. You could have illicit drugs. Certainly people take illicit drugs to cause some sort of change. Obviously, we're dealing with prescribed medications or over-the-counter medications that people take in order to feel some sort of, or to get a change, whether it be an aspirin to help with a headache, or lisinopril to help us with blood pressure, whatever it is. Tums, you can buy Tums at the grocery store or even a gas station. It's still a medication. You're taking it to cause a change because maybe you're having some heartburn and you're hoping to reduce the acidity of your stomach to help reduce that heartburn. But that's what drugs are, just chemicals introduced to the body to cause change. Nurses' responsibilities. So what are our responsibilities as far as the medications are concerned? Probably the one that most people are familiar with is to administer the drugs. Nurses are going to administer the vast majority of the medications that are ordered. The doctor does administer medications from time to time. In surgery, depends on the type of surgery. The anesthesiology does that, which is still a doctor. Sometimes at the bedside for certain procedures, the doctor has to deliver certain medicines based on policy. But for the most part, any drug that's ordered, you have to administer. So certainly check your policies to make sure that it's a med that you're supposed to administer, but just know that for the most part, the nurses administer the drugs. When we're administering a medication, there's a couple things we have to be aware of. One, we have to provide patient teaching. Every time you give a med, you need to teach the patient about the med. Doesn't mean you go into great detail. Doesn't mean that we talk about, let's say a medication we'll call Stevens-Johnson syndrome. You would just educate them, hey, sometimes people do develop a rash with that. It can turn into a serious rash. So let your doctor know if you start noticing, an odd rash. You would teach them like that instead of saying, well, this can cause Stevens-Johnson syndrome and all of your skin to slough off and possibly even die. You can kind of see how that may not be the most effective way to teach people. It's a very rare condition that happens. Certainly they need to know if they start developing kind of a weird rash, talk to their doctor. But if you start telling them, well, all your skin may fall off and you'll look like that lady from Hellraiser, that's probably not conducive to them being encouraged to take the medication. So we're going to provide patient teaching, and we're certainly going to warn them of some things that they need to watch out for, but we need to do so in a way that still encourages or that informs them. We want them to be informed, but we also don't want to discourage them from using the medicines and scare them away from them, especially those medicines that they really need. So we're going to provide patient teaching, what to look out for with the med, what they need to know when taking the med, and of course dose regimen. How to take it. We are going to work to prevent medication errors. That's another responsibility. There's things that we do to prevent medication errors. During lab and clinical last semester, you learned all about the 6 rights and checking the medicine 3 times. That's a big part of preventing medication error. Understanding what the medication is and how it's to be administered and what for is a big way of preventing medication error. So maybe the doctor wrote an order and you've got the information there and the med is correct and it's all there, everything looks good, but really it doesn't make sense to give this patient that med. And if you didn't think that deep into it, you could still cause a medication error. Yes, it was written as a certain med at a certain dose and all this marches out and it's written for John Smith. Great, that's John Smith, date of birth, whatever. All that junk works. It looks good. But it really isn't the right med for them. I've had this happen before where docs have written for medications and it all looked good. I could do my 6 rights, 3 times and it all looked great. But I'm like, doc, this doesn't make any sense to give this patient this medicine. They're not even dealing with this. And he's like, oh my gosh, thank you for noticing that was supposed to be written on bed 10, not bed 9. Happens all the time. So that's one part of medication. So of course we're going to do our 6 rights 3 times, but we're also going to think, does this medicine make sense for this patient? Does it fit the patient profile? Another nurse responsibility then, of course, once we give them the med, is assess for the effects. Now, that doesn't mean to only assess for the good stuff or the bad stuff. So if we're giving them lisinopril, we expect lisinopril to bring their blood pressure down. So we're going to assess for that. We're going to look for that. Is it working? Is this medicine doing what it's intended to do? But also, lisinopril can give people a dry cough. And more concerning, it can cause facial swelling and even throat swelling. It's called angioedema. We would be assessing for that. There's other little effects that medicine can have too that we'll look for. So we're going to assess for how is that medicine affecting this person. So again, we're going to administer the drugs, provide patient teaching, prevent medication errors, and assess for drug effects. And lastly, we're going to intervene to make the drug regimen more tolerable. And what we mean by that is there's certain meds that can cause some untoward effects, but the benefit of the med still outweighs the risk for the patient. So we will try to come up with a way to help them deal with these side effects. One that comes to mind for some people, iron makes their stomach hurt. But if they have iron deficiency anemia, they need that iron. So we can give it sometimes with just a little bit of food, and that will help their nausea. You'll see that with certain penicillin medications or antibiotics. There's a lot of antibiotics like that. Penicillins are the ones that come to mind, where they gives people an upset stomach. So you give them a little bit of food with it, and it helps. There's other meds that we'll talk about through the semester, where we'll talk about what's the best way to take this med and to help them deal with some of the side effects when they've been prescribed that med. So again, we're going to administer the drug. We're going to assess for drug effects, intervene to make the drug regimen more tolerable, and provide patient teaching and prevent medication errors. Sources of drugs. So there's two primary sources. The original are natural sources. Plants, animal products, inorganic compounds. This obviously was where medicines first came in, from way, way, way back in history. People used different plants and animal products to elicit changes. Whether it was the willow tree when they were, having pain or fever, which ended up being aspirin. There's lots of natural compounds out there. And then there's synthetic sources where we do genetic engineering of certain elements to make these medications. Bacteria are used, other things are used to help make those meds. So those are the common sources of meds that as far as where we get these chemicals. How we get a medicine to market and what we do with it afterwards, that's the drug evaluation. They all have to go through some sort of evaluation to make sure that the chemical and the medication is safe, generally speaking, for the public. There's different phases to this. The first phase is your preclinical trial, and this is where we test on laboratory animals. Once the chemical is passed through that phase, it goes on to phase 1, where we test on human volunteers. These are healthy human volunteers, normally male, because the teratogenic effects are teratogenic. I always mess that up. But anyways, the effects on the potential effects on a fetus or the sex cells. So females are born with all the sex cells that they will ever have, whereas men, make sex cells forever, right? We're just always making them. So females have a higher risk of those effects. But not to say you won't see females using this, but primarily it's healthy young men, and they're volunteers. Phase 2, so we found that so far it seems to be fairly safe for consumption. So with phase 2, the drug is tried on informed patients. So these are people that have whatever disease process is being tested. and they're informed about it, and they're saying, okay, do you want to be a part of this trial? They can opt in. Again, they're still volunteers. They don't have to be a part of the trial. So they're informed patients. So phase 2 for informed patients. Phase 3 is the vast clinical market. So in phase 2, the benefits outweigh the risk. It seems like it seems to be safe. It's ready for vast clinical market, but we're still watching it closely. Docs still have to do reports on these medicines. And then phase 4 is just the continual evaluation of the drug. So any drug that's out there, they're still watching over those medicines. There's medicines that have been out on the market for years and years, and seem to be doing okay, but then people start noticing some trends with people that are taking those medicines, and they look and they say, oh, you know what, we never noticed this potential adverse effect. And they will either have to now start putting the warnings on the boxes and include that in the patient teaching, or just pull the medicine altogether. So those are the different phases on how we get these drugs to market. Pregnancy categories really aren't used as much, although they are still but on the bottles nowadays, it really just says what potential effects these medicines can have, and it's more specific instead of just saying this is a category A or this is a category B. But let's still go through the categories, because again, you will still see this in the literature, and a big part of your job is to be able to decipher that literature and help make it make sense for the patient. So pregnancy category A traditionally means human studies have not shown evidence of fetal harm. Category B, animal studies show no risk of fetal harm. Not enough human information yet, but the animal studies show no risk of fetal harm. Category C means animal studies may show some adverse effects, or there just hasn't been any animal studies. Category D is when we really start looking at those risk benefits. Human studies show there's possible risk. Not to say you won't see somebody on a category D, but it would really be a risk benefit thing. The benefits would have to outweigh the risks. Category X, there's proven risk. There's not a possible risk anymore. It's a proven risk, and the risk will always outweigh the benefits. Women who are pregnant or thinking of becoming pregnant will not take category X medications. There's a proven risk with those medicines. All right, so the FDA studies the drugs and determines their abuse potential. So the FDA determines the potential for abuse, and then the DEA enforces that control. So we have these controlled schedules. The Schedule 1 drugs are the ones that are high potential for abuse, and they have no accepted medical use. Like heroin. Certainly certain opioids are used. Heroin is an opioid, but heroin itself as an opioid is not used. It's not accepted for medical use. Psilocybin is another one that's the drug component of mushrooms that people take to get high. So those have no medical use right now. So they're Schedule 1. So again, high potential for abuse, but no accepted medical use. Schedule 2 has a high potential for abuse, and in fact, their potential for abuse could be higher than a Schedule 1 in certain cases, but there is an accepted medical use for them. Opioids that we give for pain are the traditional ones I think of with Schedule 2s. Your morphine, oxycodone, I should say. Those types of medications, high potential for abuse, higher than some Schedule 1 medicines. But we do use those for accepted medical reasons. And what we need to understand about that is we as nurses are giving these meds that can be highly addictive. and people can abuse them. Even more so than some of the Schedule 1s, but we're still giving them as nurses, so we need to be careful. We need to be doing lots of education to people to say, hey, only take this when you need it. Don't take more than prescribed, those types of things. Like be really watching for that. From there, it just gets into levels of abuse as far as what's the potential for abuse with these. So some of them have less potential for abuse, some of them have even lesser potential for abuse, and that's really where it goes from there. So Schedule 3 just means less abuse potential, but still can cause that dependency. Schedule 4, there's still people that can become dependent upon those medicines. In Schedule 5, there's still a limited potential for dependence. But again, from Schedule 3, 4, and 5, it's just which these meds are a little more likely to make to be abused and make people dependent. Like a Schedule 3 is a little more likely than a Schedule 4, and a Schedule 4 is a little more likely than Schedule 5, and a Schedule 5 is a little more likely than most medications. So that's really what those mean. The most important thing for me, for you to understand, as far as my perspective is, Schedule 2 meds we give every single day. If you're a floor nurse or a surgery nurse or just about any nursing that you do, you're going to be giving Schedule 2 meds or being responsible for Schedule 2 meds every day. And you need to respect the fact that those meds are just as likely to cause abuse and dependence as a lot of Schedule 1 or illegal medications. So we need to respect that. All right, man, so generic drugs. Is there a difference? Does it matter? Can you take a generic levothyroxine as opposed to Synthroid? Or can you take, a generic metoprolol as opposed to just plain, or the brand name Toprol? What's the difference? Chemically, the active chemical itself, the levothyroxine or the lisinopril or the metoprolol or the diazepine diazepine, that chemical itself is all the same. There's no difference in the chemical. The difference is in the non-active chemicals, and these are called binders. When you take a pill, the whole pill is not the chemical, the active chemical. It's actually mostly binders just to help stabilize that chemical and allow it to disperse in your body in the environment that it's supposed to disperse in. So if it's designed to dissolve in your stomach and then make it to the duodenum and then be distributed that way, or if it's designed to make it through your stomach but then dissolve in the duodenum, however it's made, that's what your binders and the different chemicals that make up the majority of the med are. And those can be different depending on which pharmacy made the medicine. The pharmacy that makes the brand name medicine is going to make it the same way with the same binders on the same equipment forever. That's just the way that those meds are made. That's the way they make that med. That's what gives them the right to sell that as a brand name. Generic medicines, again, the chemical are the same. So the patents run out. You can now have a generic, which is good because it's far more cost effective. But the people that make those, the pharmacies that make those, it could be various pharmacies throughout the country that make them. And they can use different binders. They can use different things to make that pill. For the most part, people aren't affected. For the most part, most people can tolerate a generic drug just as well as a brand name drug. However, there's a difference in bioavailability. Bioavailability is just the way that your body makes that chemical available to whatever receptors are supposed to accept the medicine and get it distributed to wherever it's supposed to be in the body. And again, for most drugs, no problems. Some drugs, though, the way that people process them, especially when they're really minute amounts, such as levothyroxine. Levothyroxine is a medicine that's dosed in micrograms, right? So you can you could have like 25 micrograms, very, very small amount. If there's any change in bioavailability due to the binders that are being used, you could drastically reduce the amount of that medicine, which is also a hormone. So it's not only very tiny amounts, it's a hormone. So that causes certain, if your hormone levels don't stay at a certain level, it causes potential problems. Those medicines, sometimes the patient needs to stay on the brand name, because they know it's going to be the same every single time they take it. It will always be the same. So dispense as written just means must be dispensed exactly as written. So if the doc writes Synthroid 50 micrograms daily, the pharmacy has to give you Synthroid 50 micrograms daily. If the doc doesn't check that dispense as written or write dispense as written, then he will write Synthroid, but the pharmacy will automatically give you the generic because it's way cheaper. And I think that's a federal law now, actually, that if there's a cheaper alternative, they give you that. However, we got to make sure that if the doc wants them to be on Synthroid, so our responsibility as a nurse, that the doc has checked that dispense as written or has written dispense as written, and that the pharmacy understands that they need to give them that. And it's important for us to know that when we're giving meds. I've ran into that a few times. Levothyroxine is the most common, but I've also seen it with metoprolol. I've seen it with different meds where the person was allergic to one of the binders that some of the pharmacies use. And so rather than take that risk, they would just rather have this one specific name brand where they know they're not allergic to any of the binders. And so they didn't want what the hospital was giving them, because the hospital is going to use the generic all the time. But if they need a name brand, then we'll have to make sure that we're making adjustments for that. So that's really the difference. So generic drugs are just medicines where the patent has run out. They can now be made affordably, or at least more affordably than what you can get the brand name for. And different pharmacies can make them, as long as they pass the inspection to be able to make those types of meds. But the problem comes into what types of binders are they using, and how is that person affected by it? The vast majority of people can take generic drugs just fine, but sometimes there is a problem and they need that brand name. So over-the-counter medicines, they're available without a prescription. We're all probably pretty familiar with them. I'm sure mom gave you over-the-counter medications when you were younger. Some were originally prescription medicines, such as fluticasone, right? Fluticasone used to be a prescription medicine. Now you can go to the store and buy Flonase all day long. Budesonide, pantoprazole, there's a lot of them. Some of them are grandfathered in. So they were always available forever, ever since people have been making medicines, before we really started to regulate them so tightly. And they just went ahead and kept them out there because they were so widely available. Aspirin is the typical grandfathered medication. And over-the-counter medicines are fine. However, just because they're over-the-counter doesn't mean they're necessarily safe, and we got to keep that in mind. We have some nursing considerations to make here. So patients may not think OTC drugs are medicines. That's a big thing. So when you're doing your medicine reconciliation, which means the patient comes in, you've got to look through all the meds that they're on and verify that they're taking them. They will give you a list of meds. Typically, especially when they're older, they have a list in their purse or in their wallet or their their son or daughter or somebody, their spouse, somebody's got that list with them, and they'll hand it to you. And it will have, the warfarin that they're taking, the DIG that they're taking, the whatever, all the medicines they're taking. It's very rare, though, that they also have the over-the-counter medicines they're taking, and we need to ask about that. And then ask how often they're taking it. Because maybe they'll be like, you know what, I do take an ibuprofen. How often do you take it? Oh, maybe once every couple of weeks because I get this pain in my wrist, or I get this backache when the kids, I have grandkids for a week and blah, blah, whatever it is. Or maybe they're taking that ibuprofen 3 times a day. Very important to know. They won't always think of that as a med, so they won't tell you about it. So we need to take that into consideration. From there, we need to think about, are they taking it safely? Is this safe? Is it safe for them to take 500 milligrams of Tylenol 8 times a day, every day? Is this okay for them? What are they taking that for? Why are they taking it? Is this safe? We need to think about, in that regard, if they're taking 500 milligrams of Tylenol a day, 8 times a day, there's something obviously going on there. Are they masking some symptoms there? Or are there some signs and symptoms of underlying disease there? So we need to think about that. Are they masking signs and symptoms of underlying disease? So again, they may not think the OTC drugs as meds. They may not be using them safely, or they may be overdosing themselves, or they may be masking signs and symptoms of underlying disease. And then, of course, we always want to think about interventions. So do you take any medicines? Any over-the-counter medicines? Yeah, you know what? I take an aspirin, a 325 aspirin. I'm betting I'm taking it every other day because, man, my arthritis is really killing me, and that's the only thing that's been working. Well, they're also on warfarin. Is that smart for them to take a 325 milligram dose of aspirin every other day with warfarin? Is that increasing their risk of bleeding? We need to think about these things. We need to let the doc know and start thinking about, do we need to make adjustments? What do we need to do? So we always want to think about, are there potential interactions with the over-the-counter medicines with the prescription medicines? Remember, over-the-counter medicines, yes, they're available, but it does not mean that they're necessarily safe. You can absolutely overdose and to fatal consequences on over-the-counter medications. So we always want to assess those. Anytime we're talking to a patient and ask them about their meds, they'll give you a list of them. Make sure you always think or say, okay, what over-the-counter medicines are you using and what herbal medications are you using? Yes, herbal medications are just as important to know because they can certainly interact with plenty of prescription medicines. Sources of drug information. So you're working at the bedside. You get an order for a med that you're not very familiar with. It's going to happen every day. You need to know where to look, and you need to know how to look this information up because you're going to find 5,000 pages of information, and it may not all relate to your patient. The patient's certainly not going to read through all that. He's going to really expect you to be able to teach them appropriately. So where can we get this information? One place, the drug label. The drug label itself will give you some information. The package insert from the medicine. The medicines usually comes with this. It's usually a piece of paper. It's about 1 inch by 2 inches. And then you unfold it and it ends up pasting an entire wall, right? You unfold, it's the thinnest paper in the world, and it ends up unfolding to be like 12 feet by 12 feet. It's got a bajillion big words on it, but that does have some information. Remember though, that comes from the drug manufacturer, so it may not be the best source of all the information, but it's still a good source. It's still a reputable source. It's still a good source, but so you can use it. Just know that there may be some more things in there we may need to look up if we have some concerns. The most common places you're going to look are reference books. So the unit you work on or wherever you work may have the Mosby's drug guide there, or whatever drug, the Davis drug, I don't care, whatever drug guide they're using. Or the most common nowadays is Micromedics or Cardix or whatever those are. There's whatever system your hospital or place of employment uses, you go into the MAR. Once you click on the medicine, it'll bring up a link that says information. It usually says micromedics or whatever it is that they're using. You click on that link and it gives you that 5,000 page printout, but in a more user-friendly design where you can just kind of click through the things you care about, like indications, normal dosages, adverse effects, what to look for, nursing considerations. That's probably where you're going to get the most information. You can also use peer-reviewed journals. Again, make sure it's a good journal. It's got to be a peer-reviewed journal, not Dr. Smith's Journal of Homeopathic Medicines or whatever. It needs to be a peer-reviewed journal. The internet's a fine source as long as, again, it's a reputable source that you're using. The Mayo Clinic, Cleveland Clinic, even drugs.com is pretty well referenced. It's got to be a well-referenced source. Up to Date is a fantastic source. You got to have access to that. A lot of hospitals will have access to that, so it's fine. And then there's certain apps. You have a Lippincott app. Again, totally fine as it gets all well-sourced information. All right, so that's the basics of Chapter 1. Let's get into Chapter 2, drugs and the body. So what's the body doing with these drugs? What are these drugs doing with to the body? So we talked about pharmacotherapeutics already. Remember, the nurses deal with pharmacotherapeutics. It's just a fancy way of saying clinical pharmacology. So we study the drugs or effects on the body and what the body or how the body responds to the drug. Pharmacodynamics, that's how a drug acts on the body. So the actions, the therapeutic range, the adverse effect, that's pharmacodynamics. Pharmacokinetics is what the body does to the drug. So you take a drug, how is it absorbed into the system? How is it distributed? How is it metabolized? And then how is it ultimately excreted? Those are just some basic terms of pharmacology. You don't need to go super deep into those. Just understand pharmacodynamics is how the drug acts on the body. What's the action? What's the therapeutic range of this drug? And what kind of adverse effects? So what are we trying to get done? And then what other adverse effects may come through this drug? Pharmacokinetics, again, is what the body's doing with the drug, is how it's absorbed, distributed, metabolized, and excreted. Categories of action. Drugs can work in different ways. They can be used to replace. Think of hormones with this, like insulin, levothyroxine. So somebody's thyroid's not working appropriately. It's not putting out enough thyroid hormone, T4, T3. You will take levothyroxine or give them levothyroxine to help with that, right? So they're replacing what needs or what the body's not able to do naturally. Insulin, right? People are no longer able to make insulin for various reasons, for whatever reason, and type 1 diabetes, or maybe they got type 2 diabetes, whatever. They need insulin replacement. Sometimes we use it to stimulate receptors, right? We're stimulating. What's funny is opioids, people would probably think those as a depressant, but they actually stimulate mu receptors, which cause that drowsiness and all that. But it's stimulating the receptor. Sometimes we use it to depress the receptor or to block that receptor. And sometimes we take them to interfere with processes, such as like antibiotics. We are taking those to interfere with the biological process of those bacteria. So interference. So replacement, stimulation, depression, and interference. Action. The onset of action is the time that it takes to reach the minimal effective concentration. So you take the med now, and onset of action is 30 minutes, and let's say it's 11 o'clock. You would expect the onset of action to occur around 11:30. That's when they first start feeling some of the effects. The peak action is the highest concentration in the body. And then duration of action is the length of pharmacologic effects. And it's important to know duration of action, especially if it's a long duration of action, because if they did get overdosed on a medicine that stays in the system for a long time, we need to act to reverse that or to get rid of it somehow. Certainly, depending on how much someone gets, even on a short-acting medicine, we sometimes would have to reverse it if they got too much. But sometimes on those meds, you just watch them sit on for a while, make sure they don't get any more of that medicine, and see how it goes. But that's duration of action. Some meds have a very, very, very short duration of action. Adenosine is the common med I think of as far as short duration of action. I mean, we're talking seconds. Adenosine is in your body and out of your body. I'm sorry, as far as action goes, over in seconds, thankfully, because that medicine stops your heart, which is good. Sometimes we need to restart the heart or reset it. Whereas warfarin has a very long duration. It's 2 to 5 days. So someone's therapeutic level, if their drug level of warfarin is very high, we may need to do something to reverse that, because if we're trying to just wait it out, depending on how high that is not an option. So it's good to understand duration of action. Therapeutic range. So again, that is the length between minimum effective concentration and minimum toxic concentration. What matters to you about therapeutic range is those narrow therapeutic ranges. There are some medicines that the therapeutic range is very close to the toxic range, and they can become toxic quickly. Some examples of this: digoxin has a narrow therapeutic range, and vancomycin has a narrow therapeutic range. During this class, we're going to talk about meds occasionally, and I'm going to say this is a narrow therapeutic range. And whenever you hear that, whenever you hear this drug has a narrow therapeutic range, immediately think, okay, my nursing considerations are, I need to know what the levels are as I'm given this med. I need to know where they're at. I need to know how to assess for overdose or toxicity, because there's potential for toxicity there because of the fact that, the minimum effective concentration and toxic concentration are so close to each other. And that's what that means. So again, whenever you hear narrow therapeutic range, you know you're going to need to monitor for the drug level. And that's why it's important to you. Absorption. This is the movement of the medicine or the chemicals into the body fluids. Okay, this is how your body gets it into the system. Most affected by the route. So of course oral is going to be the slowest, and IV would be the quickest, right? It goes straight into if you stick it straight into the vein, right into the bloodstream, it's there, it's in the system. There's no real processing there. So you get the full strength, not really any absorptive effects, if that's even a word. But whereas PO, obviously, it's got to go through the system, it's got to be absorbed in. Distribution. This is the movement of the drug through the body to the tissues. This is where we get it to wherever it needs to get. Protein binding is a big part of that. The drug binds to the protein. However, when the chemical is bound to a protein, it's inactive. It would have to get unbound from that. And then there's also just the free drugs. They're not bound to proteins. Those are the ones that are able to cause the response. Don't get crazy deep into this. Just understand distribution means the movement of the drug through the fluids or through the body fluids to the tissues. Metabolism. This is the breakdown of the drug. This is the liver is the primary site of metabolism. It does the majority of the metabolism. When you take a drug orally, it's actually, when it's pulled into circulation, it actually goes into the hepatic portal, which puts it through the liver. And not every drug, definitely not every drug, but a lot of drugs go through what's called the first pass effect. Meaning the liver metabolize and break down some of those medicines before it ever gets to your body, so it's destroyed. Like a large percentage of that dosage is destroyed. So you will see some people, the doc will order like 5 milligrams of metoprolol IV, and that's what's been sustaining him. And he's like, okay, I'm going to move this to PO, and he's going to write him for 25 or 50. Again, IV, they're getting all of it, and they're getting it right then. Whereas PO, depending on how it's designed, first off, it's going to go through a first pass effect. It's going to lose some of its effectiveness, and depending on how it's designed, it may also be designed to be distributed over a long period of time. So that's metabolism. Again, liver is your primary site of metabolism. And the first pass effect is that inactivation of some of the drug prior to action. Elimination. So the primary site of elimination is the kidney, or are the kidneys. I guess you got 2 of them. Well, most people have 2 of them. Through urine, right? Kidneys process your blood and get rid of just get rid of the waste products and also get rid of the excrete the drugs, chemicals that way. Other areas of elimination are feces, right? Lungs, we breathe out. Sometimes meds are excreted that way. Think of a breathalyzer test. Saliva, sweat, breast milk, and even bile. Now, half-life, what we mean about that is that's the time it takes for half the drug to be eliminated. So if you took 200 milligrams at 8 o'clock and it's got a half-life of 2 hours, so in 2 hours, half that drug has been eliminated, or should have been typically. That's what that means. It's on the typical person, this is how long it takes to eliminate half the drug. So at 10 o'clock, you would expect there to be 100 milligrams. Now, so at 10 o'clock, there's 100 milligrams. At 12 o'clock, that doesn't mean now it's gone. That means at 12 o'clock, it would be another half, so 50 milligrams. So see how it was, you took a 200 milligram pill at 8. At 10 o'clock, it got down to 100. At 12 o'clock, 50. At 2 o'clock, 25, and so on and so on. Now, I get it. That means it will never hit 0. Let's not go that deep. Just understand that the half-life means, generally speaking, it takes this long for half the drug to be eliminated from the body. Factors influencing drug effects. One of the more common ones is weight, especially with kids. But even with adults, you have a person who's emaciated, very small. You would not maybe use the typical adult dosage, or at least not start out with the typical adult dosage with that person. You may start with a smaller dose than that, or the doctor would. With kids, a lot of medications are weight-based. They're so many milligrams or micrograms per kilogram. Age, older adults, everything slows down as we get old. It all slows down. So it takes longer to get into the system, but then it takes longer to get out of the system. So it stays in the system longer. So yeah, it takes a little longer for it to start working, but once it starts working, it works a lot longer. So we need to take that into effect, and that into effect, you know what I mean. And sometimes that just means dosing ranges. We may extend them a little bit or whatnot. We'll make adjustments based on that. And then, of course, children sometimes, especially younger, very younger children, they can't process meds as well. Or maybe they process them quicker because they're, adolescents. Their metabolism's through the roof. So that's another factor. Gender is a factor. Physiological factors. So maybe your acid-base balance or electrolyte balance, or something's going on. Pathological factors. Let's say you've got maybe a vascular disease and you're not able to it's harder to distribute that medicine. Maybe it's an antibiotic. It needs to be distributed to your lower extremities, and you've got some vascular problems there that would affect the drug's effect of the medicine, or I'm sorry, that medicine's effect on the body, because it's just harder for you to distribute it there. Genetic factors, genetics always play a role. Immunological or drug allergies, I mean, obviously if you've got an allergy to medicine, that would certainly affect the medicine, or have an effect on you in that medicine. Psychological, just the attitude. Does the person believe this medicine is going to work? It really does affect the person. I mean, the placebo effect, I'm not going to say that every medicine's dependent upon that. However, there is certainly research and evidence out there that shows the people that believe the medicine's going to work, they're going to have a more positive response with the medicine for a few reasons. One, their attitude, that does help, but also they're probably more prone to actually take the medicine appropriately and as designed. Whereas if you don't believe it's going to work, first off, you may not even stop at the pharmacy to get it, or you may stop and get it and you never take it, or you may take it for like a day and only take it maybe once instead of 4 times a day. You know what I mean? Like, you're just not as invested in it. You don't believe in it, so you're not going to take it appropriately, and that will affect. There's environmental factors, drug tolerance. So as a person takes the drug, for longer, they may become more tolerant of it, and so they may need more of that medicine to cause the effects that they're looking to get. One of the common drugs that you'll see that with is morphine. People who are on hospice that are later in life, when they're in hospice and they're later in the program, and they can be taking buku amounts of morphine, like enough morphine to kill everyone in the class, right? It's just a ton of morphine, or maybe it's a benzo. They're taking a ton of a benzo that you're like not really comfortable giving because, gosh, this would kill anybody. But they've just become so tolerant of that medicine, and they're in so much pain they need that. There's other medicines that certainly can occur, but that's one of the traditional ones I think of, because I know in the first few hospice patients that I took care of, I was very leery of giving the amounts that were ordered, because I'm like, man, this would kill anybody. But they become tolerant of that medicine. They become dependent upon that in a certain way. We need to make sure that we're covering their pain. Certainly always question it if you feel that feeling. That's a lot. There's nothing wrong with questioning it, but at the same time, just expect that does occur, and sometimes we have to give higher dosages. And then the cumulative effect. This can happen when you have decreased elimination. So maybe somebody with kidney problems and they're not eliminating the drug as quick as we would expect. So we expect the half-life to be 6 hours, right? So we're telling them to take it however every 4 times a day, whatever. But they've got kidney disease or kidney issue, and they're not able to excrete it that quickly. They're not doing the typical half-life. That drug will continue to build up. So if they keep taking it, it'll continue to accumulate in their body. Drug-to-drug interactions. So when can a drug interaction occur? And just think, a drug interaction basically is going to potentially could occur anytime you take 2 or more drugs, right? When you take 2 drugs, it's a potential that those chemicals could interact with each other. Whether or not they interact at the absorption level, so one drug prevents another drug from being absorbed properly. There's meds that can do that. The antacids are typical for that type of thing. Distribution, so they could affect they could compete for the same protein binding sites to get to wherever there need to be. Aspirin and methotrexate, they compete. They're very competitive. So we can call some toxic levels of the one, which I think aspirin is more receptive to those proteins. So the methotrexate would be the one that would become toxic. It doesn't matter. Just understand that they compete for the same sites, so it would affect the levels, affect the way that those those drugs interact with the body at that point. Metabolism. So they could stop or block, one drug may stop or block another drug from being metabolized. Warfarin is commonly affected in this way by medications like barbiturates or things like that, can affect the metabolism of warfarin. Excretion, they can compete at the excretion site. There's different meds that can do that. And then site of action. So they both affect the same receptor, where they're competing for the same receptor, and that will certainly cause a drug-to-drug interaction. Sometimes that's good, though. Sometimes we want that. Like one obvious interaction, or site of action interaction would be Narcan or naloxone with an opioid, right? So somebody's gotten too much of an opioid, they've overdosed. We want an interaction to occur with the naloxone. Naloxone is going to go in there and knock it off. So they're competing for the same site, the same receptor. Luckily, the Narcan is going to win that fight. Unfortunately, not for long. But we'll talk about that later. All right, so that's those are drug-to-drug interactions. They can occur anytime two or more drugs are taken together. Drug and food interactions, your book is going to recommend that most meds are taken on an empty stomach, and that's usually the recommendation by for most medicines, 30 to 60 minutes before a meal. That's usually what they want. Some drugs, however, have to be taken with foods because of the potential for an upset stomach. Certain foods interact with drugs, though. The common one we think of is grapefruit juice because it affects an enzyme system in the liver, so it affects metabolism. So it can either increase or decrease depending on how it's affecting that metabolism of that drug, the levels of those drugs. So grapefruit juice can potentially affect medications, and it's the one that we think about. And we'll cover those medicines through the semester as we get to them. Drugs and labs. So some drugs can alter lab results. That does occur. Aspirin usually is, or iron, both aspirin and iron, are usually not recommended before a stool sample. Usually you have to hold those for so long before they test for, it's called a heme test. It's a stool heme test. They're looking for blood in the stool. It can give you a false positive. There's others. There's tons of others, but that's one of the classic ones I think of. Primarily what you're concerned about with labs and drugs, though, is monitoring medication levels. And which principle did we talk about where it's most concerning as far as lab levels? If you would go back to what we talked about in the last chapter, it was the therapeutic range, right? Those with a narrow therapeutic range have, we know we're going to have to look at lab values. We know we're going to have to concern ourselves with the potential for toxicity. And one of the ways we monitor that is with lab values. All right, Chapter 3, Toxic Effects of Drugs. With this, we think adverse effects, right? That's what we're looking at, the undesired effects of the drugs. They can occur with any medication at any dose. It doesn't need to, just because they're taking the correct dose, like, okay, so typically we start with 10 milligrams of drug X, right? That's the typical starting dose for an adult. We go from there. The person can take 10 milligrams just the way it's prescribed and have adverse effects. So it doesn't have to be an overdose. They're just undesired effects. They can be unpleasant, such as the chronic cough or the nagging cough that people get with lisinopril. Or they could be downright dangerous, such as anaphylaxis, right? Anaphylaxis can occur with certain medications. Well, anyone can be potentially allergic to just about any chemical, but some of them are a little more common than others. Obviously, that is just an immediate emergent danger to that person. Other common terms that you may hear: side effects, adverse reaction. you'll hear those types of things. It's all just adverse effects. The types of adverse effects, we have a primary adverse effect, which means it's just an extension of the desired effect. Let's use lisinopril again as an example. The goal of lisinopril, normally anyways, the reason why we're taking it is to lower our blood pressure. It's a blood pressure medicine. It's a really well tolerated blood pressure medicine for a lot of people. Not everybody, but for a lot of people, it's very well tolerated. And that's the primary concern with that. The desired effect with that is low blood pressure. However, or lowering blood pressure. When you take medicine that can lower blood pressure, that we're given it to do that, it can cause your blood pressure to go too low for various reasons. Maybe it was too big of a dose for you. Maybe you're having a cumulative effect. Or maybe you're just having a sensitivity to that drug. We can have sensitivities to chemicals where we expect people to react this way, but they can overreact to the chemical. It's called a hypersensitivity. We'll talk about that in just a second. Whatever, they have an extension of that desired effect. Secondary is an undesired effects that are in addition to the therapeutic effect. So let's talk again about lisinopril. Lisinopril we take for blood pressure. However, secondary, it can cause that cough that we talked about. It can also cause angioedema, or the swelling of the face, even tongue and throat, which we'd be extremely concerned about. So those, we don't take it for those things. We don't give a medicine to cause a cough or to cause angioedema. It's just one of those undesired effects that are beyond the intended effect of the drug. So again, primary intended effect. Your lisinopril, your intended effect of lisinopril is blood pressure, or to lower blood pressure. However, you could lower it too much, and that's a primary adverse effect. Right, it's the most common adverse effect of just about any drug is too much of the desired effect. Warfarin, another example. We take warfarin to cause thin blood, right? However, we could thin the blood too much with warfarin. It's got that narrow therapeutic range. It's one of those narrow therapeutic ranges that we're going to be checking levels on all the time. You can get too much of that, and your blood could be too thin. Then we could lead to dire effects, right? And then secondary is in addition to the therapeutic effect. So again, lisinopril, that's that nagging cough or the angioedema. There's other things as well, and we'll talk about that when we get to lisinopril. Hypersensitivity is an excessive primary or secondary response. So we talked about somebody could take that lisinopril, and for whatever reason, the way their body reacts to it, actually get a hypersensitivity to that primary effect, and blood pressure can go way low. So it's an excessive response, and it can be either primary or secondary. But it's just an excessive response. Causes of adverse reactions. One of the most common, obviously, would be taking too much. You take too much of a med, the likelihood of having a primary drug adverse effect or go higher, right? Take more lisinopril than what your body needs or could handle, you are most likely going to see low blood pressure. And you're most likely also to see some of the other non-therapeutic adverse reactions, or the secondary adverse reactions. Drug has other effects on the body besides the therapeutic effect, just like what we talked about with the secondary effects. And again, the patient is just sensitive to the drug being taken. That's another common reason for adverse drug. Drug allergy. So what is a drug allergy? When you take a medicine, sometimes your body will, for whatever reason, have an immune response to that chemical, and they'll make antibodies. And then the next time that you're exposed to that allergy or to that chemical, you will have an allergic response to it. So it's not normally on the first dose that you are allergic to it. If that happened, if somebody had an allergic reaction to the first dose, they were probably exposed to either that chemical or a chemical that's very similar, which we'll talk about that with cross allergies and sensitivities, at some point in their life, and their body had come up with antibodies and saw that chemical as the same thing and went ahead and attacked it. and formed the the histamines and all that, which caused the allergic reaction. So it's normally on either the second. It could be the second dose, or it could be the 7 millionth dose, whatever. It's a one of those, whatever the next exposure is, that after you've made those antibodies. So people that take penicillin, and they've taken it multiple times for different infections, and then they take it, this next time, oh yeah, I've always done fine with it, and then they start to have, the rash and all that. They can still have an allergic reaction to it. They just eventually became allergic to it. Eventually your body decided, no, for whatever reason, we're going to have an immune response to this drug and make antibodies. A cross allergy is a drug associated or is an allergy associated with drugs from the same class. So you're allergic to penicillin, all right? If you're allergic to penicillin, you're also allergic to ampicillin, because there's that cross allergy there. They're not necessarily the same exact drug, but they're the same class of drug, penicillins, right? So whether it's traditional penicillin or amoxicillin or ampicillin, they're all psyllin based. There's going to be a cross allergy there. If you're allergic to penicillin, you're not going to take any of those meds. Cross sensitivity means an allergic response to one drug predisposes you to an allergic response to a drug of a different class because they're chemically related in certain ways. The traditional one I think of is sulfonamides. So if you're allergic to sulfonamides, you could potentially also be allergic to thiazide diuretics. So there's a cross sensitivity there. So again, cross allergy, same class. So if you're allergic to if you have allergic reaction to a med in a class, you're most likely to have an allergic reaction to all the other meds in that class. Cross sensitivity means you have an allergy to a drug in one class. These other classes have a similar chemical structure, so you are at higher risk for having an allergic reaction to those drugs as well. There's a risk there for cross sensitivity. All right. If a client has an allergic reaction, we want to make sure we include that in the response. So the first question you should have, if somebody says they're allergic to a medicine, is what reaction do you have? That's the first question. So do you have any drug allergies? Yes, I'm allergic to penicillin. Okay, so what happens? That's super important to know, because maybe it's actually not an allergy. Maybe it's just an adverse reaction that they have, right? There's a difference. So what's your response? Oh man, my stomach gets upset, and I have some loose stools, Okay, so that's actually not a drug allergy. Now it's an adverse reaction. I'm certainly going to mark it in their chart, so if there's another drug that we can use because they have a sensitivity there to that. But maybe the penicillin, maybe the amoxicillin, or maybe the Zosyn. Maybe the Zosyn is what is absolutely best for this medicine. And Zosyn is a penicillin-based drug. The doc will know, okay, so maybe we should have them, we should give this medicine with some nausea meds or some antidiarrheal meds or whatever the doc decides. I mean, there may be some ways that we can help them deal with those adverse effects. Whereas an allergy, so I'm allergic to penicillin. Okay, so what happens with penicillin? That's what you're going to ask. And they're like, oh my gosh, I broke out in hives. My tongue started to swell up. I was having difficulty breathing. Oh my God. Certainly, please don't take penicillin or anything that looks or acts like penicillin. Okay, that's a true allergy. If they tell you they had a rash, they get hives, they get, funny feeling in their throat, anything like that, that's now we're definitely concerned. Anything they tell you, we're going to put in the chart. Okay, it makes my toe turn purple. Well, that would be a weird response, and it would probably be pretty concerning. So I'm going to put that in the chart. I don't know what kind of allergy that is, though, but I'm going to make note of it, right? Or, oh, I don't like the taste of it. Well, that's fine. Take it with some juice or something. I don't know, but we'll talk about it. But again, it's not a true allergies. If they talk about, they start swelling, things like that. And certainly if they get full-blown diarrhea with penicillins and they have risk for dehydration, we're not going to try to push penicillins on them. But if they tell us their stomach gets a little upset, and we'll put both of it in, we're going to put that in the chart. But sometimes we need to be like, look, this is the best med for it. The docs, look through everything. let's maybe talk about some ways that we can help deal with some of the little bit of loose stools. If you've ever taken amoxicillin before, you know you get a little bit of loose stool. Make sure you have a bathroom nearby. Is all I'm saying. That's all I'm saying. Okay. Liver injury. From the first pass effect is there, right? Because a lot of meds are metabolized that way. It's the primary site of metabolism for most drugs, so liver injury is a big deal with a lot of medications. Renal injury, again, number one site of excretion, so it only makes sense that we're going to have potential for renal injury. And poisoning. Some other adverse effects that we can go over. Glucose, right? So altered glucose metabolism, like steroids, can cause hyperglycemia, right? Some meds can cause hypoglycemia. Traditional ones we think of are insulin, right? Insulins cause hypoglycemia. It's a primary adverse effect. Electrolyte imbalances like hypokalemia or hyperkalemia. So if we take furosemide, also known as Lasix, that is a diuretic, and it's a loop diuretic, so it causes lots of diureses, and we can lose potassium that way, so it can cause hypokalemia. However, some medicines cause hyperkalemia. So depending on where the diuretic works, like a potassium-sparing diuretic works further along the nephron after we've collected the potassium back, so we can potentially cause hyperkalemia. ACE inhibitors, which is that lisinopril we've talked about. Another potential adverse effect of lisinopril, this would be a secondary effect, is hyperkalemia, just because of the way it affects our aldosterone system. Sensory effects can also occur. Ocular damage, so blurred vision, color changes, blindness even. Auditory damage, like tinnitus or loss of hearing. Vancomycin is famous for potentially causing that. Also, furosemide, aspirin can cause tinnitus. So those are some other possible adverse reactions. Teratogenicity, which I always have a horrible time pronouncing. I think that's the best I've ever pronounced it, so we're going to go with it. I'm going to keep recording. That is the effect of the chemical on the fetus or embryo. So the ability of a drug to cause harm to a fetus or embryo. So what drugs can potentially affect the fetus? So we've talked about pregnancy categories already, right? We know that there's some drugs that have a pregnancy category A where human studies have shown, not really haven't shown any risks yet. Pregnancy category B means animal studies, right? And so on. And up to an X, which means absolutely there's definitely risk to this child. So you cannot take this drug if you're potentially pregnant or becoming pregnant. But that said, even though we know there's category A, that doesn't mean those are necessarily still safe. They need to... This is what's going to happen. Now that you're in nursing school and once you become a nurse, everyone immediately thinks that you know everything about everything. And you probably do too, but that's okay. You're going to get people, Cousin Flip Flop and Uncle Jim Jam are going to come up to you and be like, hey, is this safe to take? So Cousin Flip Flop's like, I'm pregnant and I just want to know if it's okay to take some acetaminophen. And you're like, well, typically they do, but at the end of the day, I'm not telling you it's safe to take a peppermint, right? You can be like, my stomach's upset and I read somewhere that peppermint makes it feel better. I don't know what you're talking about. Call your doctor, right? The bottom line is any medicine could potentially affect the fetus. So they need to call their OB. Do not take that responsibility and go, oh yeah, man, I know that my doctor gives it, this XYZ medicine to pregnant people all the time. It doesn't matter. Just do not take that risk. Because if anything, God forbid, were to happen, believe me, Cousin Flip Flop's going to be wandering down to you and just have all kinds of things to say. So as far as teratogenicity prevention, what nursing considerations do we need to make when we're teaching people about these medicines? And first thing is, again, all medicines have that potential to affect the baby. So before starting any medication, talk to your doctor, talk to your OBGYN, see if they recommend, what dosage they recommend. So maybe that medicine is fairly safe for a woman who's pregnant. However, maybe not at the normal dosage. Maybe it's safer at a smaller dosage. So you don't know that. You don't, and even if you do know that because you've talked, don't make any suggestions. Just all you can say is, you know what, you should probably talk to your OBGYN just to make sure, because you don't know their whole history. You have no idea what's going on with them. Maybe that doctor doesn't want them taking acetaminophen, or maybe they don't want them to take peppermint, whatever. They need to always consider, risk benefits. They need to understand that there's always risks involved with everything, so always consider your risk benefits. And then when we say, another thing that you want to make sure you're teaching is when we say all medications have an effect or a potential effect, we mean all medicines. We mean herbal medications. We mean over-the-counter medications. Don't start anything at all without talking to your OBGYN and seeing what's safe. Maybe that herbal medicine is okay, but at certain dosage or certain levels. Instead of taking the whole pill, you want you to take half a pill or whatever. And again, as a nurse, even if you work in an OB clinic, right? Unless you're like if you become the OB nurse practitioner and it's your job to prescribe these, fine. But as far as we are concerned, as far as just a registered nurse, no matter what someone asks you, just say, you know what, let's talk to the OBGYN about that, because there's so many considerations that need to be taken into account when we're dealing with potential teratogenicity. All right, man, chapter 4, we're almost done with this PowerPoint. I'm excited. I know you're excited. We've already talked about nursing responsibilities, so let's just run through them again one more time just to make sure that they're, in our head here. First thing, administer the drug, right? That's your responsibility. It's not the first responsibility, it's just the one that's most common that we think of. We also are going to assess for drug effects. Once we give the drug, we're going to make sure we're assessing for both positive and adverse effects. Sometimes we need to intervene to make the drug more tolerable. So maybe they have certain adverse effects, and there's some things that we can do to help them with that, right? Provide patient teaching. Every time we give a med, every single time we give a med, okay, we've given this med to this patient 3 times today. I do not care. You're going to do the patient teaching each time because they're not going to remember it the first time. They may remember some of it the second time. They'll remember more of it the third time. That doesn't mean you have to do the same speech every time. You could be like, hey, you know what? Remember we took this medicine earlier. What do you remember about it? That is patient teaching. They can recall. And so whatever they recall, you say, oh, you know what? Yes, this is correct, but this is actually, you missed this a little bit. Let's talk about that so that they have a better understanding. Or maybe you're like, oh yeah, you remembered all that. Maybe we can take this into a little bit deeper understanding of this medication. And then prevent medication errors. Remember, we're going to do our 6 rights 3 times, and we're going to make sure that they're taking it for the right reason, all of that stuff. Assessment. So what assessments need to be done with respect to medications? First thing is history. What is their drug history? What medicines are they on? What medicines have they taken? And what allergies do they have? We'll look also at what chronic conditions do they have. Are they taking medicines for those chronic conditions? What's their level of education and understanding? So, where are they at with that? You're going to do patient teaching on somebody who maybe has a developmental delay, a little bit differently than those that have like a PhD in chemistry, right? You're going to do their patient teaching is a little different. Just because they have that PhD in chemistry, though, doesn't mean they understand the meds. We're still going to teach them about the meds, and we're not going to try to use a bunch of medical jargon and talk over them either. But at the same time, you're not going to talk to them the same way that you would talk to somebody who maybe has a little bit of a delay or whatever. Social supports. Do they have people to help them with these meds? Maybe their daughter comes by and puts their pill boxes together every week, or maybe a church group does that, or maybe they don't have anyone, but you recognize they need it because they're being, they're in for CHF exacerbation. They were doing good, but lately they're getting a little weaker, or maybe they're getting a little more forgetful, so they're forgetting to take those meds, and that's what's leading to this exacerbation. They need someone to go in there. Once we get them under control, they need to go home and have somebody there that's going to be able to help them with that. So we'll want to look at that. Financial support. Maybe they've come in with a CHF exacerbation, not because that they're becoming a little more confused, or they're a little weaker and they're not remembering to take their medicines. They're just not taking them because they can't afford them. So instead of taking that furosemide every day, they're taking it every other day, or they're taking half a pill a day, or they're not taking their metoprolol, whatever it is. Happens all the time. So we need to, when we get a list of medications, ask them, okay, so how are you taking them? I know this is what this says, but how are you taking them? And if they brought the bottles with them, even better, because you can look in there and go, well, this is a 90-day supply. It's April, and you got this back in November. That's way longer than 90 days. It doesn't look like you're taking them the way that you're supposed to take them. And a lot of times it's, I can't afford them, so I'm having to cut them in half or whatnot. And you're like, well, okay, so let's see if we can figure out a way to help you with this. And then, of course, compliance goes with all that as well. And there's a million reasons why people are not compliant. Maybe they're forgetful. Maybe the regimen is just too much for them. I've put together drug regimens for people where I looked and I'm like, there's no way I, as a healthy, younger person, I'm going to say younger, I'm going to go with younger, would be able to take these and be compliant every day. It's just no way. So I've had to call multiple doctors, because there's always multiple doctors involved, and we get them on a regimen. We change some things around to get them down to, like, maybe the goal would be once a day, but usually it's 2 times a day. Sometimes it's 3 because there's just no way around it, but very rarely. I can almost always get everybody onto a 2 time a day. I'll come in and they'll have 5 different times through the day that they're supposed to take these stupid meds, and I'm like, dude, there's no way you can remember to take them like this. So we get them, we reconcile those, and we try to get them down to a more tolerable level. So look at compliance. It could be financial reasons. It could be forgetfulness. It could be they just don't like the way it makes them feel. And so maybe we can switch them. Maybe that, you know what, I take that stupid med, it makes me cough. Okay, well, let's get you off the lisinopril and put you on an ARB or something. We need to understand what they're not, if they're being compliant, if they're compliant with all their meds, and if they're not, why not? Not to punish anybody. We're not there to, you know what, at the end of the day, if you decide absolutely you're never going to take these meds, then fine. But I'm going to educate you on the importance of these meds and talk to you about why maybe you're having some of these exacerbations, and see if there's something else going on that I can help with. Financial supports, social supports. There's programs out there for all of that. I'm going to let you guys do this one on your own. Just think of 2 nursing diagnoses that are related to medications, and just kind of work with nursing diagnoses and how you can fit those in there. As far as the planning goes with these, you're planning your outcomes. What kind of outcomes are we talking about? Depending on what the med's being given for, maybe it could be just to have a positive effect of those meds. You know, so it's lisinopril. They'll have a decrease in blood pressure of 20 points by the end of the day, whatever. Maybe it's a regimen thing. Maybe it's they will understand that they need to take this medicine twice a day, with breakfast and with dinner. So at 5 p.m., maybe they want them to take it in the morning and then like early evening, so that way they're not up peeing all night. Maybe it's a diuretic. They want them to take it twice a day, but you don't want to take it at night before you go to bed. You want to take it more like around maybe dinner time or early evening time. Whatever. That may be an intervention or a potential outcome. Like, client will be able to verbalize drug regimen and the importance of sticking to that regimen by end of shift or whatever. There's multiple ones. There's all kinds of them that you can come up with. As far as interventions are concerned, obviously education is the big intervention, and you're going to do that with every time you give a med. You're going to do patient teaching. That's a big intervention. Another intervention is just checking to make sure they took the meds. Sometimes people, especially people with dementia or with or I guess Alzheimer's, dementia, whatever, they pocket the med. Sometimes they pocket it on purpose. They don't have Alzheimer's or dementia, anything like that. They just pocket it, and they either save it for later or they spit it out because they don't think that medicine's going to work anyways. So you can always check. to see that they've actually taken it. There's all kinds of different interventions. When does patient and family education begin? Obviously, we teach with every dose we give all the time. So it begins the second a medicine is ordered for a patient and that we're going to give them this medicine, and it is repeated as often as they're with us and that we're giving them that medicine, right? So as long as that medicine is being given, we're going to teach them about it every single time. And again, it doesn't mean we go in there and give them the same spiel over and over again. It means we go in there, we give them, the normal teaching. We've assessed what their learning level is, right, and what they understand. And then we give them some information, the important nursing teaching. And then with subsequent doses, we'll kind of test them on that. Just, hey, so do you remember what this is? Remember what we got to watch out for? This is warfarin. Do you remember? Oh, yeah, I got to watch out. Make sure, look for bruising, maybe dark stools, and then if I do get cut, I need to hold pressure on it for a while. And if it doesn't stop, within 10, 15 minutes, maybe get a hold of the doctor or something, whatever it is, the teaching that you gave. So again, it's repeated constantly, like every time we give a medicine throughout their stay. As long as they're getting that medicine, we're going to continue it. Evaluation, we look and see, okay, so is this working? Is our plan of care working? What's going on? Are the meds having the effects that we're expecting to have? And it can lead us to other care plans and other things that we can do for them. 6 rights. These are the primary rights of drug administration. There are other rights that we need to consider, such as reason we talked about earlier, right? That's not really necessarily one of the 6 typical or primary rights, but it's still something we always need to make sure we're thinking about. But the primary ones, the ones we are concerned about up front, patient name, right? We're going to do 2 patient identifiers. The typical 2 patient identifiers are name and date of birth. Drug. Triple check the drug, right? We're doing triple checks on all these. Dose, we're going to verify the amount. Is this the right time? So we're going to look at the timing. Is it on schedule? It's supposed to be due at 9 a.m. It's 9:30. We are golden. Okay, it was due at 9 a.m. and now it's 11. It is no longer the right time. We need to think, okay, do we need to reschedule these meds for different times? So I need to get a hold of the pharmacy. I definitely need to get a hold of the doctor and let them know. There could be a completely legitimate reason why they got a med at 11 o'clock instead of 9. Maybe they were in surgery, or maybe they had a procedure, or maybe they were vomiting, right? If they've been vomiting for the last 2 hours, the last thing you do is try to put a drug down their throat, right? It ain't gonna work. It's just gonna come right back up. So there could be easily legitimate reasons for that. But we need to make sure we get a hold of the pharmacy and the doctor and see what we need to do about the schedule. Route. Is this the correct way to give the medication? I have had horror stories of nurses that we've worked with over the years that have given a medicine in the wrong route. And the one I think of immediately is a nurse that, so in the ER, we usually have 2 different types of Recephin available to us immediately. We have an IM type, which has to be reconstituted, usually with lidocaine, and it's a small amount, normally not more than 3 milliliters. And then we also have a IV amount, an IV type that is 10 milliliters. And it's already reconstituted for us. We just get it in a syringe. It's the same dose, though. It's a gram. Now, you can push out however much you need. So if they order 750, you can go down to 7.5 with the IV, or you can just draw up. And again, I don't know off the top of my head what the dosage was on that. It was a gram and like 2 points. Who cares? It doesn't matter. You could do the calculation to get it to 750. It's normal dosage, nursing dosage calculation. Well, the nurse grabbed the 10 ml syringe, which is actually the IV, when it was when it was ordered to give IM, and she gave an entire 10 cc's IM to a child with just not very positive results. That is an extreme instance of wrong route, right? So did not obey the 6 rights of administration. So we're going to check these rights 3 times before we give it to the patient. We're always going to think, am I sure this is the right route? There's a pill that actually is breathed. Spiriva is actually an inhaled medicine, but it's a pill. Now, you don't inhale the pill. You actually put the pill in this special device, and this device punctures the pill, and there's a powder in the pill, and that device helps distribute that powder to your lungs. If you give it PO, it does nothing. It just comes out. You just have this nice purple pill or blue pill or whatever comes right out of your feces, right? So you have this, I guess it decorates your poop, but it does nothing for you. So that would be, again, the wrong route. And then documentation. They have the right documentation. If we don't document immediately, the next nurse may not think that medicine was given and will go ahead and give it again. I have definitely seen this in practice, especially when we had paper charts. But it could certainly happen. It could definitely happen with electronic chart, because an electronic chart is just a record that you gave the medicine. If you go and give the medicine, you can totally hand somebody a pill without ever getting in the chart. And I've unfortunately seen that. And if you don't remember to go into the chart and mark that you gave it, the next nurse is going to go, oh, that was never given, and they're going to give it, and now we can overdose a person. So right patient, right drug, right dose, right time, right route, and right documentation. Proper drug administration, there's some more rights that we need to think about. We already talked about reason. Does it make sense why they're taking this medicine? Okay, so they're in with pneumonia, and the doc is, and they're not having any pain with it. They're just having some, cough, and a little shortness of breath, and you're working at a clinic, and the doc writes for 2 milligrams IM morphine for pain, but they're not having any pain. The doc wrote that order, and you stop and think, is there a good reason why we're giving it? I'm going to ask the doc, man, you know what? They're in with pneumonia. We did the x-ray. Looks like they're having some atelectasis, probably some pneumonia. I mean, they're not complaining of any pain. Are we sure? You're always going to ask the doc. And it's not to say we don't give morphine for shortness of breath, but not for clinic shortness of breath. It's usually a very severe shortness of breath that somebody's having. That person's probably doesn't make sense. I'm gonna question that. And you're gonna see this all the time, where every once in a while doc puts in an order on the wrong patient. It happens. It's not a good thing to happen, but at the end of the day, we are there to catch that mistake. We are just another filter in the line before it hits the patient. So just think about right reason. Preparation. Is it prepared properly? We do prepare meds, especially, we reconstitute meds all the time. So we're reconstituting it with the right solution and in the right amount. Is the med, did pharmacy accidentally put a medicine in a bag that's not of a solution that's not compatible? That does occur. It's extraordinarily rare, but there's definitely cases of it out there. And then storage. Has it been stored properly? Expiration date, right? That's part of storage. We always have to check expiration date. I had a student who found lisinopril, and it was pretty well expired. And when we were pulling them out, she's like, oh, look, this one's expired. I'm like, oh, that's weird. It probably just got shuffled to the bottom or something, and somehow we ended up with it. But whatever, we'll just put it over here, grab another one. She grabbed it, and she's like, it's expired. And I'm like, okay, well, let's look at all the lisinopril. And by God, I think it was 75% of it was expired, which luckily left us one pill that we could actually give. So we took all the expired med out. We sent it to pharmacy with a note saying, hey, look at this. Pharmacy came back. We didn't hear anything back for a while. So I was like, well, pharmacy, whatever, they're dealing with it. A few hours later, at the end of the day, when we're about to do our discussion, the pharmacist actually comes up and thanks us for catching that, because they have now went through the entire hospital and found expired lisinopril throughout the entire hospital, including the ICU. So always check expiration date. And then there's some medicines that have to be refrigerated, right? They can only stay out of the refrigerator for so long. There's certain meds like nitroglycerin. Has to be, when it's the pill, it's got to be in that dark glass vial, right? Or dark glass bottle. If it's been sitting out of that dark glass bottle, the lights have affected it. It's no longer any good. There's other medicines that are exactly like that. They have to be in a dark bag or a dark vial or something. Always just know, is this being stored properly? Has this been stored properly? When I had my daughter, she had an infection. I went to the pharmacist, picked up the prescription antibiotic, went home, gave her the first dose. For whatever reason, didn't take that and put it in the refrigerator or put it on top of the refrigerator because, that's what you do. And then I came back to give her the next dose, and I'm like, where the heck is that med? And I look up, and I'm like, darn it. And I knew I had to go back to the pharmacy and explain that it was all my daughter's fault. Anyways, so again, storage. So right storage, right preparation, right reason, and don't just blame everything on your daughter. Obviously, I didn't do that, but all right. Patient's role in medication safety. They still have to take some responsibility, right? They are responsible for keeping a written list of all medications. It's the best way to do it. I've certainly had people that don't have that list. It happens all the time, and now I'm calling their pharmacy. Now, which pharmacy do you use? Well, for these 3 pills, I use CVS, and then sometimes I use Walmart. Now, I once had a coupon for Kroger, so now I'm calling CVS, Kroger, all of them, right? I'm calling them all, and then Kroger's like, dude, they haven't been here since 1995. Like, okay, well, I probably don't need to talk to you anymore. And CVS is like, yeah, they come here every once in a while. They were here for a couple years, and then they took a year off. And then last time that they came in December, but they only got one medicine, and it was like iron. And then you call Walmart, and they're like, well, we sent all their information to Pills R Us because they do them all. They send them to them in the mail. Like, oh, son of a gun. So now I'm calling Pills R Us. Believe me, that's literally, I've done that I don't know how many times. And they'll give me a list of pharmacies, and then inevitably I have to call another pharmacy that they totally forgot to tell me about. And I've honestly had it where that forgotten pharmacy was the primary pharmacy. It just occurs. So keep a written list of all medicines. Know what the medicines are for, and that is up to us to teach them, but they need to retain this information if they're able to do so. Follow the directions, right? They need to, if they can't follow the directions, we need to have somebody that can help them follow those directions. Understand how to store that medicine appropriately and to do it safely. And then, of course, speak up. If they see something that's out of normal or out of whatever is their normal way of doing things, or something that they don't feel right about, or just speak up if they start having adverse effects. If they start noticing adverse effects, this isn't something you have to live with. It's not, there's ways that we can help with that, or maybe that medicine's just not good for you. So maybe you're not allergic to it, but you're having some pretty sensitive reactions to it with adverse effects. They need to be able to speak up with that. Medication errors. The best thing I can teach you, the best thing that you can learn about medication errors is report it immediately. Don't think about it. Don't worry about what's going to happen to you. Worry about what's going to happen to the patient and report that. Most commonly, it's going to medication errors that you have to write it up, and most hospitals have a no-fault policy. Now obviously if you're writing up multiple medication errors all the time, there's going to be an issue. But usually what they want to see is there a systems process that caused the error? And a lot of times there is. A lot of times it's a systems problem. One error that I can think of, I had a new nurse orientee who's, honest to God, one of the best nurses I've ever worked with. She was new to our hospital, but definitely not new to ER. She had quite a few years in the ER. We back then had paper charts, and the patient had Dilaudid 1 milligram ordered. So she knew that. She saw the doc, wrote it. So she went and grabbed it. And then when she came back, she didn't see the chart sitting there. She figured the doc had already grabbed the chart again to write more orders. So she ran in, gave the milligram of Dilaudid, and then came out, not knowing that another nurse had just walked in and gave the milligram of Dilaudid. So this patient now had 2 milligrams of Dilaudid. That certainly, no doubt, that nurse needs to own up some of that responsibility, no doubt. But there's also a systems problem there. That chart, there should be a way for the nurse to always have their hands on the chart. And believe me, back then, that was not the case. The doctors had those charts all the time because there was just one chart. And there's the one chart you did the meds from and the one chart that all the orders were written on. It was not safe. So shortly after that, actually, we ended up going to a different system. It was obviously a systems problem. Definitely the nurse had, to take some responsibility for that. But at the end of the day, we realized it was primarily a systems problem. So just report it. Report it and obviously call the doctor, and then watch that patient. Now, when you make a drug error report, always follow your policy, because there's certain reports that you can't put in the patient chart that has to be filed in a separate way, whatever, yada, yada, yada. Know that through the policy. But report it. I always think patient safety first. Do not use abbreviations. Write that stuff out, man. Here's some do not use abbreviations. QD used to mean daily or every day. You can see how that would be a problem. QOD is every other day. We do not use that. You never use QOD. They need to write out every other day. U can stand for unit, but the problem with that is it can be interpreted as all kinds of stuff. Because believe me, I have horrible handwriting. Somebody may see my U and think it's another 0. Instead of giving 10 units, they give 100. So obviously that would be a big deal. So we don't use U or IU anymore. IU is international units. We just use units or international units. We spell it out. MS is morphine sulfate. You'll still see doctors write MS-20 or whatever, meaning morphine. So that's not appropriate. Or MS2, right? They'll say MS2 IV, whatever. It's not appropriate. They need to write out morphine sulfate. MS could mean all kinds of things. 0.5. Anytime we're writing a number, a fraction number, or a decimal, I'm sorry, it needs to be written out with the whole number taken into consideration. So if it's a 0.5, it needs to be 0.5. There needs to be that 0 there before the decimal. If it is just a whole number that doesn't have a decimal, you don't need to put a decimal. So it's not 1.0 milligrams, it's just 1 milligram. That 1.0 could easily be mistaken for 10, and there's no reason to have it there if it doesn't need to be there. So if it's a 0.5 or a 0.2 or a point, who cares? You put the 0 in front of it so that they can see that place marker, so it's there. If it's a whole number like a 1, 2, 3, 4, we don't need anything behind that. We don't need 0. That one is not a needed place marker, so we don't need that. So just get rid of it. As far as pediatric pharmacokinetics go, influencing factors with absorption, of course, weight and age. We've talked about that. Route is the most concerning thing with absorption, right? As far as how quickly that occurs. And then health status. What can affect absorption? Well, all kinds of stuff. For PO, gastric acidity, the ability of that stomach to empty, and the motility of that. IM sub Q, that's perfusion and circulation we're worried about. For IV, obviously it's immediately absorbed, so we need to think about that. This is immediately being absorbed. And then topical, with kids, their skin sometimes a little more porous, maybe a little thinner. So that can affect topical as well. As far as distribution is concerned, body fluid composition is a big deal. Infants are like 70% water, right? Whereas adults are like 60% water. That affects distribution. There's more or I'm sorry, there's less body fat with infants, so that can affect it. They have less protein binding ability, less protein receptor sites, so that affects distribution. And a big deal with distribution with pediatrics is the blood-brain barrier. In infants, it is immature. That blood-brain barrier protects your brain from certain chemicals. The certain chemicals are not able to get past that barrier in order to affect your brain, which is an awesome thing. However, babies or infants they have an immature one, right? They're very underdeveloped. So some meds that on adults are safe because they don't cross that blood-brain barrier aren't necessarily safe on babies because they do cross that blood-brain barrier. As far as metabolism, they have a decreased hepatic metabolism in neonates. That's going to affect the metabolism rate. So decreased hepatic metabolism in kids less than 2. Now, kids that are children, after we get into the toddler age, child age, they actually have increased metabolic rate. As far as excretion is concerned, children less than 9 months have decreased elimination capacity. Nursing implications, meds, again, they're ordered like we talked about before on weight-based, or that's the consideration we're going to make is weight-based considerations. As far as cognitive or developmental considerations, just think about that. With kids, there could be a compliance issue there, or are they able to even take that medicine themselves? Do we need to just physically give that to them? Obviously, a baby, we do, right? We put it in the dropper, and we feed it to them on the side of their mouth, just a little, or we put it in like a little bottle of, whatever works for them to take it. So we need to think about that. Is there some considerations that need to be made with this child and how they're able to take this medicine? Some kids, they've been dealing with maybe growth hormone, right? They've been taking somatropin forever, so they can totally take that pen and stab themselves with it, right? They can inject their own somatropin, better than some adults that I've had to teach to take, insulin or whatnot, or to do injections. So we'll always want to assess that. Family involvement. Let's get the family involved. Make sure that we're doing our teaching with the patient, but the family's there, especially when they're younger kids, and the family's the ones that's going to be reminding them to take these meds or helping them with these meds. We need to make sure we get those patient family involved with that. Geriatric pharmacology, technically anyone over 65. Just the big thing to think here is everything slows down, right? Absorption slows down, distribution slows down. It all slows down. It takes longer to get in the system, but then it lasts longer in the system, right? Adverse drug reactions, they're more frequent with these because think about it, they're taking 85% of the medicines. And if you're taking most of the medicines, you're more likely to have more adverse reactions. Polypharmacy. Polypharmacy just means taking multiple drugs, right? Just multiple drugs. And again, the elderly population are taking the majority of those drugs. It's obviously common in older adults. Some ways that we can help prevent it. One is just use one pharmacy. If we can get them just to use one pharmacy, that pharmacist will do med reconciliations every time. And I've definitely seen patients with 2 or 3 different orders and pills that are the same. Not for any reason because they needed to have these different pills, just because one doctor ordered it in this dose and one doctor ordered it in this dose, not having any idea that these 2 doctors had ordered the same medicine. So if they're getting them from different pharmacies, which actually happens way more than you probably realize, it can be a big deal. keeping a list of all medicines and the reasons why, and sharing that with every provider so they can look at that and know, okay, these are the medicines they on. And as far as nurses go, we can if we're doing good medication reconciliations every time we see that patient, the docs and the nurse practitioners, everybody will know what meds they're on before they prescribe more meds. What factors influence adherence? Polypharmacy is a big one, right? Multiple drugs taken multiple times each day. That schedule can be a big deal for people, and it can be hard for them to stay compliant. Impaired memory, they just forget to take the meds. Vision or hearing loss, right? If you're not able to read the labels very well, you may be taking the medicines wrong. Maybe it says twice daily and you didn't read that and you just start taking it daily, or maybe you're taking it twice daily when it only says daily, or maybe you're taking one pill instead of two. Whatever it is, you just can't read it. So vision problems. Cost of the drugs, we talked about that. If the drugs are too expensive, people don't take them, or they take them less often than they're supposed to. Child-proof bottles are actually a barrier potentially for some people. Now, we definitely want those to be in place in places where it's needed, but some places it's not needed and it's actually a hindrance. Adverse effects. I don't take that water pill because it makes me pee all night. Okay, well, maybe we should try taking it during the day. So that way you pee during the day. And sometimes people don't take it because, well, I'm real active, and I go to my, I'm active in my church 3 days a week, and I don't want to be active in my church and peeing all the time, or I don't want to be going out with the girls every Tuesday and Wednesday and peeing. So whatever it is, sometimes it's those effects cause people to not take them. Lack of understanding, just not understanding it. And sometimes it's just an intentional. Sometimes they're just like, you know what, I just don't want to take this medicine. So how can we help them? How can we help them become more adherent to these medicines? Help them with, if it's a senses issue, let's help them with that. Maybe get them bottles that have, the medicines written in a bigger font, or, treating people with respect is always helpful. If you are teaching somebody about meds and you're doing it in a disrespectful way, or doing it in a way that they don't, they feel as though you're just trying to rush through it, they're not going to take the medicine as seriously, right? Because if you're not taking it seriously, they're not taking it seriously. Review all medications every time or with this patient, every visit, whether they're, if you're a home health nurse, every time you visit them, you're reviewing the medicines and making sure they understand what they're taking, or when they're coming into your clinic, whatever. Encourage simple dosing schedule. We talked about that a little bit already. If they're on meds 5 times a day, no one can be compliant with that. We need to get that down. Try to get down to 2-3 times a day. 2 would be best. 1's the best, but sometimes that's impossible. Sometimes we just can get it down to 2, but that's certainly better than 5, and they're more apt to be compliant. I use pill organizers, right? Maybe set reminder alarms. We've all got supercomputers in our pockets now. The elderly population do too, and we can just set their iPhone or whatever to go off on certain times every single day, and that's just going to remind them, oh yeah, I got to take my pill now. So there's lots of different ways to do it. Those are just some few ways.